Medical practice behind bars has unique challenges, and there are unique ethical challenges that come along with that. Number one, there's the matter of professional isolation. Physicians and other healthcare workers behind bars tend to be wholly isolated from their counterparts in the community, and so their ecosystem is different. The evolution of care behind bars has been different from the evolution of care in the community, and that in general has been detrimental. So while we have competition in the community for continuity and coordination, and particularly for clinical performance measurement, behind bars we haven't evolved to that extent. Secondly, there's a tension between healthcare culture and prison culture. Prison culture is a command control culture. Command control likes things black and white, yes or no, right or wrong. And healthcare professionals are selected to be able to deal autonomously with uncertainty, and that autonomy and uncertainty is alien to the correctional culture. As a result, the correctional health professional has a dual loyalty by nature. They have a loyalty to their professional ethics and their professional integrity, and at the same time, they must have a loyalty to the institution. If they can't balance those loyalties, they're going to be out of a job. So they have to pick their battles, pick their issues, and work as really effective communicators with prison authorities so that they can advocate their best for patients. Confidentiality is always compromised in prison, whether one wants to do that or not. So that poses one of the unique ethical challenges. There are access barriers to care, often with low-level nursing staff, licensed practical nurses, for example, making decisions about who gets to see patients with higher level care. And perhaps the most dangerous, the most virulent of the unique challenges behind prison is the stereotyping that tends to happen. It's almost a contagion that healthcare workers who may come in just out of school or just out of training, who are idealistic and vigorous in their interests to care for individual patients, get poisoned, or they get poisoned by the stereotyping, the minimalization, the stigmatization of prisoner issues, all of which adds up to cynicism. Confidentiality is illusory because correctional officers, for the most part, are going to know who goes where, who gets medicine, and who doesn't. If the AIDS doctor is in today, the officers have to bring inmates down to see that clinic. They know officers in the healthcare unit know who's waiting to see that doctor. Likewise, for people who are on medications, there's always an officer accompanying the nurse who gives out the medication, so officers know, almost have to know. Prisoners who are in infirmaries or on mental health housing units, the officers know what those units are and they know what it's for. So there's very little that can be held confidential. Perhaps certain conversations between a clinician and the doctor can be kept private. They can be in the medical record, which generally is kept from correction staff, but correction staff know where the inmates go, they know who they see, and they know that they get medicines, if not what medicines they get. In 1976, there was a Supreme Court decision in a case called Estelle v. Gamble that interpreted the Eighth Amendment of the Constitution, the amendment that prohibits cruel and unusual punishment, by saying that inmates had a right to timely access to an appropriate level of care, and they had a constitutional right to care that's ordered by a physician. They further defined this right as a right to this timely access to care for people who had serious medical needs. That decision, based on the Eighth Amendment of the Constitution, was a really important driver for improving care, particularly through litigation, through class action litigation all across the country, to try to make sure that inmates weren't punished in a cruel and unusual way through a denial of medical care. But that constitutional basis is fixed in 1976, and medical care in the community has evolved substantially since that time. We have learned a lot about patient safety practices. We've learned about prevention. We've learned about patient-centered care and the value of using clinical performance measurement to reduce morbidity and to reduce mortality. And there's a lot of scientific evidence for that, but there's no constitutional basis for it. So I'm afraid that the constitutional basis for care, which was so important in improving care in the few decades after 1976, is going to be less and less useful as time goes on. What we don't have is the public policy and the leadership to move correctional health care into an era where there's an attention to outcomes, particularly value-based outcomes. How can we integrate care for people with dual diagnoses, for example, people who have addiction and or mental illness and perhaps chronic disease? What driving force are we going to have to provide the attention and care for those people so that when they leave prison, they're much less likely to come back? We need to develop the community linkages. We need to develop diversion programs in the first place. And it's interesting that while we use the term reentry, we talk about prison to community. In Europe, they talk about through care, which looks back to the medical care that someone was receiving in the community, providing continuity and coordination of care with sharing of medical information through the course of the incarceration, and then building the linkages back to the community-based care. And that's really based on a World Medical Association and World Health Organization concept of equivalence of care. That's not to say that inmates should get care that's equal. But equivalence attends to matters of value, attends to matters of outcome, and that would include, of course, issues of prevention. So while inmates have a different spectrum of disease, high rates of chronic disease, high rates of mental illness, high rates of addiction disorders that may be quite different from those of people in the community of similar age and gender, they need equivalent care for whoever in the community has those conditions. There are challenges to informed consent outside of prison and inside of prison. We're both familiar with how rote or routine it is when we, in the free world community, have medical procedures and people they give you these long documents and say, sign here. It becomes even more difficult in prison because of the intrinsic distrust that prisoners have about the healthcare providers who they have had no choice in selecting. They do have a right to access to a reasonable level of care, but they don't have a right to choose the providers. So there's an inherent distrust of these folks who work for the agency in one way or another, for the agency that is keeping them incarcerated. and denying them of their liberties. There's also the matter of ability to communicate, whether it be language or the difficulty of communicating between people of different races, different genders, different cultures, and different levels of education. So those are all barriers to effective communication, which become barriers to getting informed consent. But that's not to say that patients in prison don't have a right to their autonomy. They do. They have a right to make autonomous decisions, and health professionals behind bars have an ethical standard to meet, and that is to communicate sufficient information to the patient about whether they want to proceed or not proceed. And this ranges the gamut from communicating about a medication that the doctor wants to prescribe or a surgical procedure that's recommended, but it also comes down to good communication about what harm might come to the patient if they refuse. I would develop a prevention program for stereotyping and cynicism. As I look back over the course of my career, one part of which has included a lot of litigation where things went wrong, people were injured, or they ended up with severe disabilities, or they died. The reason that those things went wrong was because healthcare staff were cynical, where they minimized patient complaints. There was disbelief, distrust, stereotyping that the inmate couldn't be telling the truth because, quote, they don't tell the truth. And these beliefs, which are absolutely false, become pervasive in prisons. And when that happens, there's actual harm.